So good evening, everybody. Nice to be meeting again on this platform. We are going to have a pediatric session. Topic is about the children with upper respiratory tract infections, murmurs, and wheeze. And we have got a very seasoned speaker, a specialist in pediatric anesthesia, Dr. Shishir, joining today. And to give a background about the ISA Ballari and BIMS Anesthesia Alumni Group session. So this is the 29th session where we have had presentations from people of high repute, youngsters, and many interested colleagues from across the country and across the world. So this has been a monthly program. What it means is we have been doing it continuously for 29 weeks now. So this is the 29th episode. On behalf of the ISA Ballari and WIMS Anesthesia Alumni Group, we are meeting here. So I have the pleasure of having Dr. Shishir today. I request Dr. Balasubramania to introduce Dr. Shishir, followed by which we shall have the presentation by Dr. Sirish. Dr. Balasubramania, can you please introduce?
Good evening, everyone. It's a great pleasure for me to introduce today's speaker, Dr. Shishir Chandrasekhar. He is currently head of anesthesia and OT management, Sakra World Hospital, Bangalore. He has completed his MBBS and MD both from Mysore Medical College, then FRCA from London in the year 2006 and CCT in the year 2012, that is from Postgraduate Medical Education Training Board, UK. He has worked as a consultant pediatric anesthetist at Great Ormond Street Hospital, London, UK. He is member of several professional organizations, including General Medical Council, Royal College of Anesthetists, Association of Anesthetists, Great Britain and Ireland, Association of Pediatric Anesthetists of Great Britain and Ireland. His areas of special interest are pediatric anesthesia, measuring and improving quality in anesthesia, OT Kaizen and Six Sigma methodology, non-technical skills, training for anesthetists, TIVA and TCI, to mention few. With this brief introduction, now I request Dr. Shishir Chandrasekhar to take over the proceedings. Thank you.
If you can share the screen, please. Thank you.
Sure. Is that clear now? And am I audible?
Perfect.
Okay. Good evening, everybody. And I consider it an honor to be invited by Dr. Balabhaskar, whom I have admired from afar for a long time, for the body of work that you have done, sir. And you have been an inspiration to us younger anesthetists of Karnataka for a long time. Thank you for this opportunity. So over the next 20, and thank you, Dr. Balasubramania, for generous words of introduction too. Over the next 20 odd minutes, what I thought we will do is look at a common problem that we all encounter, whether we are a first year postgraduate or a seasoned anesthetic professional, whether we are a pediatric anesthetist or a generalist, or this cuts across all branches, all shapes and sizes and seniority. Because we all know that we almost always encounter a kid with a recent history of an upper respiratory tract infection, the occasional kid who pops up with a murmur, or an asthmatic kid. So these are some of the themes I would like to, in the face of it, it looks like a very exhaustive topic. So I am just going to focus on the preoperative assessment and also about how we can optimize these kids. And then I think we have a wealth of talent listening to this, and if they could contribute later on, and depending on how how much time we have, we could probably progress a bit on those themes as well. I think the first thing to understand as anesthetists is risk, and I think it instinctively comes to us as anesthetists. We always think in terms of risk. And I think for any anesthesiologist, the asymmetry of risk and reward is important to understand. By that, I don't mean financial reward. What I mean is, at best, what we do at the end of an anesthetic is leave the patient at the same way we found them, and of course, facilitate surgery. But the risks can be catastrophic, and we are all aware of that. So consequently, the traditional way of thinking about anesthesia, rightly so, has always been about safety and about not taking risk. But the real world that we inhabit means that we have to take risk, we have to assess risk, and we have to deal with it accordingly. So those will be my themes for these kind of situations today. So first, we will look at what the actual risk of going ahead with surgery is, because a lot of medicine is dogma, and we just don't, we just blanket cancellations is typically what many of us have done. But what are the actual risks? Is it able, that is something we will look at. And also the risks of not going ahead. There are certainly consequences for every cancellation that we do. More importantly, can we quantify risk, or is it just something that, again, we attribute to as art? Because most of the time when we say it's art, it's because we feel it's not measurable, and we somehow make it seem ethereal and say it's art. But I'm hoping to convince that we can actually quantify risk in these specific situations. Having quantified it, how we go about mitigating risk. And finally, from my experience as a pediatric anesthetist, what I think those tips are. And here I expect our senior anesthetists who have joined also to contribute towards the end of the talk, please. So first things first, how good are we at risk stratification? This is a large, pragmatic French study of over 7 centers in all of France. Because again, in France, much like Western Europe, the pediatric services are quite specialized, and it's done by anesthetists who regularly anesthetize children. So this is what they looked at. This first, we are looking at a child with a recent upper respiratory tract infection. By the recent, we mean in the last 4 weeks. So what they did was looked at a 6-month period of 7 different children's hospitals in France. There were 621 kids who fit the bill of a recent URTI. And then why I say it was a pragmatic study is they allowed the team to decide who they wanted to proceed with and who they didn't want. So about 130 odd kids, the team themselves decided that we will rule it out. They're too high risk. We will not go ahead. So this team included the pediatric anesthetist, pediatric surgeon, and the pediatrician. But what happened with the other 489 that they went ahead with? Again, remember, this is in a tertiary center where everyone's doing pediatrics all the time. What they found is 1 in 3 kids had a PRAE. By that we mean perioperative respiratory adverse event. That's quite a high number. And about 1 in 5 such kids whom they proceeded with had a desaturation, which they defined as saturations of less than 90% persisting for at least 15 seconds. And when they dug a bit deeper to find out what the independent risk factors were, unsurprisingly, age came up. So the younger the kid, the more the risk that we encounter. The experience of the anesthetist was interesting. I think this has also been validated by a large pediatric trial of about 300 centers in Europe called the Apricot study, which many of you might have heard of. What Apricot also said, and what these guys also found, was every year of experience in pediatric anesthesia for the person at the head end reduces respiratory complications by about 1%. So that's also something people running departments and people in more senior positions, something that we need to think about. These kind of kids, the experience of the anesthetist also mattered. And again, that dreaded outside anesthesia, outside the operating theater kinds of anesthesia, like endoscopic procedures, but independent risk factors. One of the interesting recommendations Michel et al. Came up with was that midazolam pre-medication in the dose of 50 mics per kilo was found to be protective against perioperative respiratory adverse events. Yes. But equally, if you look at the literature, there are some studies which do not back this also. But this is something that this group came up with. It was a well-designed study. So the natural consequence of as when we see in the PAC room of a kid who's had a recent URTI is, just cancel. And that's what we call blanket cancellation. But this, again, was an interesting study by Schreiner et al., now good 25 years ago, almost 30 years ago now, that came out in anesthesiology. And this is interesting numbers, because the average kid, if there is such a thing as an average child, has at least 7 episodes of a upper respiratory tract infection every year. Each time it lasts several weeks, and the airway reactivity, as we know, lasts up to 6 weeks. So what we are saying is 7 times 6 is 42 weeks. So out of the 52 weeks in a year, 42 weeks are going to be suboptimal for this kid to undergo anesthesia. And another interesting thing with the number needed to harm concept, what they came up with is to prevent even 15 episodes of laryngospasm, we would have to cancel something like 2,000 kids with a mild upper respiratory tract infection. So this obviously does not seem tenable and does not seem like a logic-based or evidence-based approach. And while safety is paramount, the consequence of not going ahead also means there's an emotional toll on the kid who's been prepared for surgery, on the parents as well, because they would have planned their life around that surgery and around the next few days of recuperation. And without sounding the devil's advocate, there is definitely a financial loss for the hospital as well by the work that does not happen. So the next logical question is, do we just rely on our gut instinct, or is there another way of assessing it? Turns out there is a good way of stratifying risk. This was a group by Lee et al., Professor Lee et al. Out of University Children's Hospital of Los Angeles, who came up with what was called the Coles criteria. This came up about 6 years ago, but it's still not really been used very much as far as I am aware. So what they looked at, this original study they did was in children less than 7 years old who had had a recent URTI. They looked at 5 components, as you can see to the left first column, if you see, whether there were any current signs and symptoms, when the symptoms started, was it on the background of normal lungs or pre-existing lung disease, what sort of airway we were hoping to use for these cases, for the surgery, and what the actual surgery was. So these were the 5, it would seem instinctively logical things to do. So they gave a score. So this is not a 1, 2, 3 score. If you notice on the the 3 columns on the right, it's 1, 2, and 5. So automatically it's not a linear risk. The risk increases the moment the pathology worsens. So if you just think of your average kid who had a bit of a runny nose about 4 weeks ago, who's going to have a small procedure like say an examination under anesthesia, they would just score 1 mark each on each of these. So their score would eventually be 5. Okay, so the maximum score you can have is obviously 5 times 5, 25. So on the other hand, the other end of this spectrum, if you see, you can immediately recognize that this is not a kid you want to be anesthetizing anyway. This is a moderate, so either they've had moderate to severe URTI, by which we mean a wet cough, abnormal lung sounds. They have looked toxic in the recent past, so less than 2 weeks ago. And in this kid is probably an ex-preterm baby with an asthma, with persisting asthma in the background, or a bronchopulmonary dysplasia, or an obstructive sleep apnea, who is now going to undergo either a cleft palate surgery or some max-fac surgery. Obviously, these kids are going to tick 5 on every single box of these. Okay, I'll tell you what happens when you actually quantify later. But more likely than not, we are going to encounter this middle kind of role. This is where the decision making becomes a bit more tricky. So for example, a child did have a bit of, symptoms wise, they did have mild URTI about say 3 weeks ago. And there's a mild history of asthma, but well controlled. And this is a kid who's going to have, say, for example, a flexible bronch or lacrimal duct probing as a fairly simple procedure, which can be done under LMA. So this kind of kid would trigger 2 on each, so it would give a score of 10. Often what happens is the real world we inhabit, you may have a kid with reasonable premorbid condition, then undergoing something fairly major. Okay, so obviously the score is a quantifiable score. So how does it correlate in the real world? So anybody with a low score of the 5 to 7, what Lee et al. Found is this was over 600 kids, I think, that they looked at data in a retrospective way from the UCL Children's Hospital in Los Angeles. So their risk of having an adverse event was less than 10%, which rose to about 20% the moment the score triggered somewhere between 8 and 10. Okay, where it started going up was between 12 and 15, and certainly 16 and 18, and the last slide is not showing up, but that it goes up to something like between 50 and 70%. So this, I think, is a reasonable way of looking at it, and then we are in a better position to quantify. So what happens in the real world? Again, what happens is that we end up, if you look at the left half of the screen, this is a kid that you would probably end up taking up, a clear runny nose with a bit of a dry cough coming for minor surgery. You would schedule it and you would proceed with it. A kid, for example, a young baby with a purulent discharge. So this is the Royal College of Anesthetists recommendation as well, where there are systemic features of the kid being unwell, which means 38 degrees and higher of fever, malaise, the kid not feeding well. This is again a good question to ask the parents because they know the kid much better than we will. So we would look at parental confirmation as well. And if the answer to any of these is that, we are ticking these boxes, again, this is another way of cross-checking with the cold score. So if we are going ahead, what are my suggestions and tips? I'm sure everybody else can also contribute to it. Here, I feel the experience of the anesthetist matters. This is not just my opinion, but multiple studies are bearing this out. So every year of experience of the anesthetist reduces your risk of having an event by about 1%, which is a pretty reasonable number, I think. A lot of these events, as we know, the respiratory, the laryngospasm and bronchospasm and all that are triggered due to anxiety and triggered at induction. So in my hospital, for example, our routine practice is to have parents in the OT with the kid, and the kid induced gas induction on mom's lap or dad's lap with STPs. That also greatly reduces the chances of, the anxiety-provoking problems. So again, when we have decided to go ahead with the case, you have to either extubate these kids fully deep or fully awake. And again, consensus is that if you have put an endotracheal tube, it's sensible to wait till the kid is fully awake. If you put in an LMA and you have done your suction deep, you can extubate deep and leave the kid in recovery position and allow them time to wake up. Where possible, we can think about supraglottic airways, because obviously the mere act of intubation increases risk, and even in your cold score when we saw from 2 to 5. So where possible, if we do not instrument the airway or minimally instrument the airway, that would seem like a sensible option. Where possible, TIVA should be considered. And by TIVA, I mean classical TIVA of propofol and remifentanil, which is still, Remi is going to come next week now, we are finally told. Because the reason I'm saying Remi is an excellent cough suppressant, okay? And that is also a good way. And in fact, it's one of the commonest indications why pediatric anesthetists in the UK use TIVA. And it's a technique that will slowly come into our system also. So TIVA definitely reduces the risk of perioperative respiratory adverse events. And one more thing that is suggested is midazolam before extubation, again, just to calm the kid down, because the other end of the spectrum is when the other risk of spasms happen. Next, we move on to a kid with murmur. And what is the actual risk? So we know congenital heart disease affects somewhere between 1 in 50 and 1 in 100 kids. So some sort of congenital heart disease they could have. What we know also is that even when they come for incidental surgery, the mere act of having any cardiac problem doubles their perioperative mortality. Again, I'm not being alarmist. What it means is, the absolute numbers are still going to be low, but the relative risk is twice as much as a kid who would not have had a cardiac problem. And all of us are aware, and this is an oft-quoted and rightly so by our teachers right from the time we start post-graduation, that especially in ASDs, any septal defects, there is always a risk of reversal to fetal type circulation, especially the younger the kid, and the risk of paradoxical air embolism, which can then get into the systemic circulation and cause serious problems. So naturally, we would be worried in any kid with a murmur. Again, the jury is quite clear about any kid who you're seeing for the first time who's under the age of 1 and has a murmur definitely needs to be investigated prior to proceeding with surgery. So there, I think everybody would be in agreement, because this is probably the first time it has been picked up, but we need to figure out quite what is wrong. It may well be that it's an innocent murmur, but it definitely merits more investigation. So again, just a bit of physics for especially the postgraduates. How are murmurs, why do murmurs happen? Murmurs happen due to turbulent flow, and when the Reynolds number exceeds 3000. So Reynolds number, as we know, is a dimensionless number, which is given by the product of the density, the diameter, and the flow velocity. and also inversely proportional to the viscosity. So if you think about a young child, you're going to have, fairly the physiological anemia of pregnancy or of infancy means that they will be, relatively less viscous blood than adults. The diameter of the vessels are going to be bigger in the sense, bigger relative to their size. They're closer to the chest wall, so you're more likely to pick it up much more quicker. Flow velocity is going to be twice as much as it is in an adult. So consequently, you're more likely to hear murmurs in a child because of a better acoustic window and also because of better velocity of flow. But what it then means is that not all of these murmurs are guilty, but there are about 50 to 72% of them, as you can see, there are innocent murmurs. So as a postgraduate or as an anesthetist who's having a kid with who listens to a murmur on examination, what helps me pick up whether it is a innocent murmur or otherwise? So this is the kind of classic 6S or 7S, you might call it. These are characteristics. Again, I'm not saying that each of these have a very high predictive value, but what generally tends to happen with innocent murmurs are that they are systolic murmurs by nature. They are short duration, less than 1/3 of the systole, typically. Grade 3 and less. So the moment they have a thrill, definitely it's unlikely that it's going to be an innocent murmur. Again, it's described variously as sweet or soft, and that is again a subjective feeling. And once you've listened to enough, you might be able to make a make a reasonable assessment. They tend to be small in area and they do not radiate much. And also important thing is that they are sensitive to changes in positions and respiration. Okay, so because this is again flow, and the moment you think about it, positioning the kid in various positions means that the acoustic window changes. And if that changes, the murmur changes, then it is much more likely to be a flow murmur or an innocent murmur. One very ominous and honorable exception to this is the murmur of hypertrophic obstructive cardiomyopathy, which is also positional. But again, that would give you other clues as well. But just for the sake of completeness, I'm saying that. And generally, innocent murmurs do not have any clicks or gallops. Gallop is, as we know, a sign of a failing heart, and much more likely, like an S3 gallop, is likely to be a kid in failure. Again, we encounter these kids in the pre-anesthetic check, and this is especially for the postgraduates. How do you assess? You can't ask for investigations for every single kid, perhaps, depending on where you're working. You may be, but if suppose you can't, even otherwise, it's a good way to, this is a good way to ask questions about the functional. What we're really interested in is the functional tolerance and the ability of the child. Can this kid run like their peers, like their classmates, like their siblings, is an obvious question that you can ask. Then, is this kid calmer or slower than their peers? Slower could be physically or mentally because of congestion, and if they have high viscosity, that also obtuns their cerebration also, actually, in the worst case scenarios. And because they can't do much, they kind of get resigned to a life of not being particularly active. So these two questions tend to pick that up. In smaller infants, always ask the mother, is the feeding more prolonged? And if they've, especially if they've had another kid, is the feeding prolonged in relation to the other baby that they had? Do they sweat during normal acts of care, whether it's feeding, whether it's bathing, whether it's clothing? Do they sweat? Because that is again a sign of a struggling heart. And again, when they wake up first thing in the morning, do they have swollen eyes? So these are good questions to ask. And if the answer to any of this is yes, definitely it needs more investigating. And again, as anesthetists, we are worried about spells and about cyanotic spells. And the way we would ask is, has this kid ever turned blue, especially the lips and the hands? Have the parents noticed this turning blue? Have they ever lost consciousness? And do they squat? Again, this is classically described in Fallow's tetralogy, as we all know. So do they stop playing and do they squat? By squatting, they're trying to increase their SVR and trying to augment their output. Investigations wise, now we have a kid with a murmur, like we discussed earlier, less than 1 year old, always think about getting it investigated. Even older ones, ECG, surprisingly, the humble ECG has the most, has good value and good predictive ability. What we are looking for are signs of chamber hypertrophy. So on the left ventricle, so if you could see V4 and V5, each small square is about 1 millivolt. So in a kid, anything more than 4 small squares or 4 millivolts is a sign of left ventricular hypertrophy, either in V5 or in V6. Right ventricular hypertrophy, which can of course also happen in a kid, is in V1 and V2. So if you can just notice here, greater than 1.75, so almost 2 squares in under 5 kids, and even more than, slightly more than 1 square in V1 and V2 of older kids. Because as you know, younger kids, by the time the normal relationship of the LV to RV is established, it's somewhere between 2 and 3 years, because the right ventricle initially is stiffer. So the RVH is more pronounced in a smaller kid, and you would need more of an amplitude than in an older kid. And again, if in any doubt, please ask for an echo. This is not long, and it's not like 30, 40 years ago where it was difficult to get an echo, and it might help us for, it's a simple way of doing it. It's cost effective, and it helps us risk stratify. What do we mean by risk stratify? What we mean is we have to accept that any kid with congenital heart disease it's not child's play, if you pardon the pun. It can double mortality even in non-cardiac situations. Anything more than the most innocuous murmur requires a consultation with a cardiologist, with a pediatric cardiologist, who the kid is probably already seeing. So when do I worry when a kid comes to me? What are the danger signs or red flags, as it were? Any kid with cyanosis is worrisome. A very young kid with a cardiac disease is worrisome. Complex defects like univentricular physiology or Fallows, naturally, they are not things that you can. It is not about who anesthetizes. Now, again, it's often a question that gets, oh, should a cardiac anesthetist only anesthetize this? I don't think that is what we are getting at. But what we are getting at is, as long as you understand physiology and are able to handle it, it's okay. But what if things worsen? Do you have the option of escalating care? And if the answer is no, these are not cases we should be taking on lightly. So those are the kind of cases we should be referring to specialist centers. Those kids with pulmonary hypertension, definitely, especially when there's a fixed component to the pulmonary hypertension and a reactive component on top of that, we are probably going to be out of our depth in handling it in a typical setting when we are not used to it. Any kid in failure, any kid with an obstructive lesion, these are not kids to be done in a secondary level kind of hospital. And arrhythmias also, because a lot of the problems in kids can be electrical as well as mechanical. And just another note, long ago, actually, NICE has come up with guidelines, and other bodies have also come up, that there is no specific role for infective endocarditis prophylaxis. It still continues to be practiced widely, but there is absolutely no role to it. Whatever prophylactic antibiotics you would have given otherwise is what we end up giving for these kids also. They do not require any specific IE prophylaxis. So far, I hope you're kind of with me. I will just come to the last bit of the talk, which is the child with asthma. Asthma, I think, is as we know, is a reversible paroxysmal narrowing of the airway. I'm not going to go into the pathophysiology. We are all aware of it. We're all practicing anesthesiologists. And what we now know is, especially in the West and in India, even more so. And in fact, I come from Bangalore, which is regarded as the asthma capital of India. So the terrible pollution, terrible air quality index means that there is greater than 10 to 15% prevalence of asthma. So this is almost seen as like a non-communicable disease, but an epidemic proportions. So the kid with virtually every other kid you see gets branded as asthma or reactive airway. And they definitely need careful evaluation, which we will come to. So suppose a kid with asthma has a recent URTI, I think it's relatively speaking a no-brainer. This kid is at extreme risk for respiratory events. So definitely sensible to postpone for at least 4 to 6 weeks till airway reactivity becomes back to baseline. Another good point to ask is if there is any history of exposure to passive smoking, and you could use this as an opportunity to guilt trip the parent also into giving up smoking, because definitely this is an independent risk factor for asthma, and it's modifiable. So how do we risk stratify? Do we, just listening to the chest, because these tend to be paroxysmal events, you cannot immediately, every time you listen to the chest, you will not find a polyphonic wheeze. So what is actually, I found very useful when I was looking around, is this really good website by GlaxoSmithKline GSK called asthmacontroltest.com. And I would urge all of you after this talk to have just play with that thing. It hardly takes 2 minutes. Okay, and it's a very useful tool we could use even in our PSC. All of us have smartphones. We could log on to that and ask the kid and their parent to complete this test. It's a series of just 7 questions. First 4 questions are asked to the child, And, you can just, so it asks something like, how do you feel today? Do you find it difficult to breathe? Have you had to stop playing because of breathlessness? And they just choose yes or no. And then last 3 questions are directed towards the parent, asking, have they been woken up from sleep with difficulty in breathing? Do they cough a lot? And compared to your other peers, are they, compared to your other kids or other kids, are they looking like they're not in as good shape? So parents tend to be very good in this kind of chronic ill health situations. So what that does is that once that, total number on that comes to as high as 27. So higher the number, the better. So any score greater than 21 means that this kid is probably going to be, to quote Jack Nicholson's movie line, this kid is going to be as good as they get. So there is no point postponing or canceling these cases, just hoping for more improvement, because this is about as good as it goes. On the other hand, if they do not trigger scores of 20, and if say 16 or 14, and again, I urge you to go and have a look at this website afterwards. It's easy to administer also. Then we start thinking about getting inputs from our pediatricians. So again, in these kids, how do we optimize? Now we know what the risk is. So let us think about how to optimize. So you can broadly categorize them into 3 sorts. Well-controlled asthmatic, not much needs to be done. The kid continues taking their normal medication, and we give inhaled beta-2 agonist about 1 to 2 hours before surgery. For a moderately controlled asthma, so in that asthma control test, the score of around 20, 21, that sort of score when they're triggering, about a week in advance of elective surgery, we can start inhaled corticosteroids and also regular inhaled bronchodilators. Now, on the other hand, a poorly controlled kid, again, we are talking in an elective scenario here, obviously. So a poorly controlled kid, you have options of these kids need a good dose of steroid, a good burst of steroid before starting surgery, okay? So at least 3 to 5 days before, 1 big dose of oral prednisolone, 1 mg per kg per day, started between 3 and 5 days before surgery, or oral dexamethasone in the doses that are just described here. In India, we don't have oral methylpred, but this is also one of the other things that if where you're working has this option, it is something worth thinking about. So how do we, on the day of, again, we will just come up to the induction and stop at that, because my talk is about preoperative assessment and optimization. So all the controller, the brown and the blue, as you know, the blue is the inhaler and the brown is the controller medications. You have to continue all of them on the day of surgery also. And again, one more dose of a short-acting bronchodilator may be useful, but again, this is more to assuage ourselves and the kid and the parents than really making any big difference in the perioperative phase. Again, anxiety is one of the key triggers for bronchospastic spells. So pre-medication with midazolam, or like I was saying, getting the parents into the anesthetic room, I find is a great help. Inducing with sevoflurane, and which is an excellent bronchodilator, is obviously a good option as well. And if this kid had been taking systemic steroids, because some of these kids are very brittle asthmatics and they often take systemic steroids, especially in the last few months, if they have taken it, we need to cover a stress dose of hydrocortisone, about 2 mg per kg also. And this has to be taken, this decision has to be taken in concert with the pediatrician. So I think at this point, I hope I have kind of achieved the objectives of what I set out to. We have now tried to understand the risks of going ahead versus the consequences of not going ahead. We've tried to quantify risk in each of these 3 clinical scenarios. We have tried to mitigate it as best we can, and I have shared some of my ideas about it. And I would request Dr. Bala Bhaskar to take it on from here and moderate. Thank you very much.
Thank you. It was a great presentation, Dr. Shishir. In fact, I was struggling to admit people in between, mainly because we had the YouTube channel also on. So we had limited 100 admissions into the session. So it was a great presentation.
Thank you, sir.
We have few questions in the chat box.
Yeah.
We can take them one by one. And meanwhile, participants who are there, you can also directly put some questions and raise your hands. We have, can we start, Dr. Shishir?
Yes, sir, please.
Yeah. So, Dr. Prema, that's the name, the mobile is named after. The question is, do kids get cardiomyopathy? But I know it's a generic question, but anyway, you can please clarify.
Definitely, they can. Typically, what we find in small babies is after a RSV infection or a Coxsackie infection, bronchiolitis, post-bronchiolitis, we often see kids who can have cardiomyopathy as well. But these tend to be more like a stress cardiomyopathy-like picture. They tend to be quite acute. And if you tide over that, most of the function comes back to normal. Yes, they can have. And we have seen, especially in a PICU setting.
Yeah. I think you had addressed it basically, but the question is there from Dr. Ramesh Kumar. Can we use midazolam before extubation? And parents are very anxious in children if they are not awake after the extubation.
As long as the parents are primed what to expect, I think it's usually a communication issue rather than parents being anxious. And what we always tell the parents is that we expect the kid to wake up when they are ready. And if the kid is cranky, it's just like, because if you wake a kid up at 6 in the morning because they have a school bus at 7, the same mood you expect post anesthesia also. So as long as we allow them to wake up when they are ready, crankiness is less of an issue, is what I always tell them. And midazolam, definitely, I feel it helps. I give midazolam in my practice towards the latter half of the case. Not that it is particularly evidence-based, but I find that initial anxiety is less of an issue as long as the parent is there. It's usually the separation anxiety that the kid faces. And once we obviate that with parental presence, it's less of an issue.
Yeah, it's basically emergence component also adds on in the second half, irrespective of URTIs and other things, right?
Very true. And again, here, TIVA probably will start playing more and more of a role once it becomes, established practice. And sevoflurane is an obvious risk factor for emergence delirium as well.
Yeah. And of course, this any of these sedatives, including midazolam, they definitely bring down the afferents of reflex arc related to laryngospasm. So that's always a benefit in any of the patients.
Very true. And again, just to, for the postgraduates who might be listening, it's a parasympathetic mediated reflex by the superior laryngeal nerve is the afferent for laryngospasm, and it goes into the nucleus tractus solitarius, and the efferent is via the recurrent laryngeal. So both limbs are from the vagus. So any reduction in that is definitely going to help. Yeah.
So what I'm just supplementing, what PG should remember is it's also a reflex. We got afferent, efferent at the center, basically. So we can cut the afferent, we can cut the efferent, and we can try to control the center also. So drugs like midazolam would be definitely not just at the central level. They would also be probably useful at the. And meanwhile, what about the role of lignocaine? Prior to extubation.
Yes. Lignocaine, what they're saying is about 5 minutes before planned extubation. It almost doesn't matter which route it is given by, whether it is topical or intravenous. It is said to reduce risk of laryngospasm. Lignocaine is one and magnesium is the other. Between 15 and 20 mg per kg of magnesium also is advocated. Yes, but I didn't go into the perioperative, intraoperative phase. But yes, both are valid points. And perhaps magnesium has more compelling evidence than even lignocaine.
What I would probably think is when we indeed think that a child is high-risk patient, child with URTA, where, for example, it is just between 2 to 4 weeks, and we are somehow due to various indications, we want to go ahead with the surgery. So probably it would be advisable to undertake these measures more proactively, right?
Sure, sir. Agreed.
In such cases, right?
Yeah.
Then Dr. Prashant Sajjan is asking, are there any specific pulmonary function tests bedside in this age group?
I think it's very difficult to do because it tends to be very subjective. But a kid, a peak expiratory flow rates is an obvious thing. And for the reversibility, the FEF 25 to 75 is done. But it's, I think, in the real world, it is so difficult to do. And how much of it is reversible? It will be reversible. Unlike an adult lung, most of the asthma by nature is a reversible condition. So as long as we control it with good bronchodilation, I don't think PFT, I don't know about your practice.
Yeah, that's true. It's quite difficult to get a compliant child to perform the PFT first of all.
Yeah.
Any grown-up child, we can promote them, especially, of course, it's dependent upon the type of the procedure also. As you mentioned, you have got multiple factors. So what is also a determinant is the type of the procedure, the duration of the procedure, the invasiveness of the procedure. So these are the ones which contribute further to the so-called outcomes. So
and one more thing I probably forgot to say, I was meant to say is when you're taking a history in an asthmatic kid, also worth asking, are they okay with non-steroidals? Because many times kids are okay, and it is an important part of your multimodal analgesia, and you cannot really sacrifice quality of analgesia just out of the misplaced fear that this kid may have bronchospasm. So it's worth asking the question, have they had ibugesic, ibuprofen, or diclofenac, and have they been okay? And if the answer is yes, in a guarded way, you could still go ahead using it.
So generally, we do think like intubation would be a greater risk as compared to supraglottic airways. That's factor one, and of course, cuffed would be more likely to precipitate because of the area of contact. Among the supraglottic airways, do you think, I don't know about the studies, I have not gone through, would IGL be a better option than inflatable ones, like, cuffed supraglottic airway devices like LMA?
Sir, I don't use iGel routinely, but in my defense, I use first generation LMAs, but I always preserve spontaneous ventilation. I feel that the airways, the LMA is a upgraded face mask rather than a downgraded tube, certainly in pediatrics. And if I am worried enough about airway protection, I would rather use a ET tube than a second generation supraglottic. And when I keep my classic LMA, I always preserve spontaneous, and that is more forgiving in terms of slight malpositions also, because I somehow feel the iGel is a pared down version of the adult rather than having been designed specifically for...
Purely for pediatrics.
Yeah. Would you agree, sir?
I do agree at this point, because we don't want to take risk, right? So if it is an adult, I would not mind whether it's a first generation, second generation, third generation, because I'm more confident in managing the airway. So, but I wouldn't want to take a risk in especially an infant, even a neonate. So that risk is always there. And I think Dr. Srinivas has also asked about the same question, role of PFT in asthmatic child, so which you have discussed already. Dr. Apurva has asked about role of airway blocks in preventing laryngospasm.
Again, it's anecdotal at best. Yes, there are suprahyoid nerve blocks have been described, but the risk of doing something versus the risk of not doing also we have to look at. And if you provide good depth of anesthesia and maintain your airway safely and securely, I don't see how it's going. Topicalizing the airway has a disadvantage also in that silent aspiration can later become a problem too. And especially if the thing is about laryngospasm, there are many other ways of, for example, with an ET tube there, to maintain a positive transglottic gradient is much more important than any other medications, because it's like if you're asking the kid to breathe spontaneously through an ET tube, it's like breathing through a straw. So at the very least, you should keep pressure support. And once we keep pressure support and do a suction deep and extubate fully awake, it generally does not tend to be a problem.
That's true. And when you just were mentioning about suctioning per se, so we are at risk, right? So in between, when you try to suction the patient in between place of or towards the end, so suction in a later plane can precipitate an episode of laryngospasm.
Yes. And when I think I saw Dr. Anju's message there to say that it has a role in refractory laryngospasm. Yeah, probably true. But in laryngospasm, once established, the inhalational route becomes less useful, because your whole idea is the problem is at the inhalational route. So the three ways of looking at it, I look at is CPAP first, followed by propofol, followed by scoline. Because the intravenous medication is what you're really believing will work in that situation, rather than giving more CO or more inhalational agent, because the inhalational route is where the problem is.
That is true. Yeah. Should we need to explain that, Dr. Vivekanand, should we need to explain the risks of laryngospasm to the parents if you take the child with URI?
Yes, sir. I think we should. And I think it's a reasonable thing to, rather than giving absolute numbers. I mean, if you put it like 1 in 3, which is actually the data-driven number is 1 in 3. And 1 in 3 is a big risk. And many parents may get things. So what I find is always, we have to still be truthful. I would still say the risk is about 3 to 4 times as much as if the kid did not have a URI, but that we are in a position to handle it should it happen. So you explain the risk and offer the the option of the cure. Then I think it's but yes, from a probability point of view, definitely we have to tell. We cannot pretend that the risk doesn't exist.
That's right.
Yeah.
Dr. Yashoda, sir, any comments on eosinophil count and AEC?
I honestly don't think about it, sir. If you have anything, please add.
Yeah, madam probably wants to know because it's a normal discussion in adult population.
Yeah.
Where we think about hyperreactive airways disease, and one of the things which we also look for is eosinophilia.
Yeah.
So probably madam has this in mind, and probably if the patient had a worm infestation. Yes. So probably it would. I think it's a pediatrician's job. Patient would have been stabilized with the pediatric advice before the patient is brought to us, and differential count is normally done at this age in majority of the patients. And if indeed there is a rise in eosinophil count, definitely we do. We are expected to be more careful in managing the patient.
And I think that kid will be on mast cell stabilizers
already
as part of pre-op workup only. Even without surgery intervening, they would have anyway been on Montelukast or some sort of mast cell stabilizer.
And inhaled, majority of the times inhaled anticholinergics also.
Yeah.
That will also be there in majority of the pediatric patients.
Yeah.
Dr. Azam, okay, yeah, he has confirmed propofol works better for laryngospasm.
Yeah.
Different dosing. Role of ketamine to relieve laryngospasm.
I think once established, ketamine is probably, it's not, instinctively it would make sense because it's a bronchodilator, but it also increases secretions. So I think it's and in established laryngospasm, definitely it will not work quickly enough for it to be of any benefit. But prophylactically, I think ketamine has been again thought of as one of the options, but we already have things like sevoflurane, which is an excellent bronchodilator. If you're a user of Tiva, you have propofol, and which is also a very good bronchodilator. So personally, I don't have much experience of ketamine.
Yeah. It must be a holistic approach. Again, if you are deepening the plane of anesthesia, where we want the muscle power to be retained and the patient to be recovered early. So I think it's a relative indication. So ketamine.
I think a very important point that Professor Balabhaskar makes, I think we should wait for at least stage 3 plane 2 before doing anything. And by that, we define it as regular deep respirations, loss of muscle tone, and central mid-dilated pupils. That is the plane at which you do airway instrumentation. And only slightly before that is when you even do cannulation, because even cannulation can trigger spasm in the stage of excitation. So once you have airway control and bring them to stage 3 plane 2, which like I said is loss of muscle tone, regular deep respiration, and central mid-dilated pupils, that is a good plane to do any instrumentation.
Something like Bailey's maneuver is acceptable. Have it done in pediatric cases, slightly elderly children.
So again, I think Bailey's becomes more of an art than science kind of thing. So
not easy to implement. Yeah.
Not easy to implement. Yeah.
That is true. Okay. If one more question is, if child develops bronchospasm after intubation resistant to treatment, would you prefer extubation in view of the hyperreactive airway or related?
I think, yeah, it'll have to be, if you think that the tube alone is the trigger, then I can see the logic of that. But again, once we take it out, where is the guarantee that it'll immediately work out? So what is then happening in a phase of laryngospasm is, in a phase of bronchospasm is, what I do is reduce my respiratory rate, give more E time, and get rid of my PEEP, because the kid is already auto peeping. So your IE ratios, if you move it to more like 1:2.5 to 1:3 and allow the spasm to settle, I feel that is a more prudent thing than trying to pull the tube out in haste.
Yeah. So, on the safer side.
Yeah.
Dr. Krishna, sir, spontaneous respiration in neonate or in pediatric patients will be difficult as there is more risk of increased secretions. It's a bit confusing.
I mean, see, a lot of the work as long as in neonates are a different ball game. Definitely, neonates you are more. I don't really put LMAs in neonates. I would intubate because those LMAs are even a 1 is for under 5 kilos. Very rarely it sits perfectly. But where you have been able to give good regional analgesia, whereas a surgeon I work with does a lot of lower limb work. Sorry, a lot of pediatric urology work. And if you've got a good caudal in that is working very well, then all you're really running it is at like 0.6 of a MAC with a LMA and spontaneous ventilation. There, I don't think secretions become an issue. But on the other hand, if you're in doubt, intubate. Nobody can criticize us for intubating. But my own experience is that if you have a good analgesia, multimodal analgesia, especially a good caudal, then perfectly possible. In 80% of my cases, I leave them on spontaneous ventilation with an LMA. And touch wood, it is not touch wood. It's not a problem. Yeah.
See, one of the initial slides you said, you had, mentioned about the experience of the anesthesiologist. So that's the one which matters in many of these discussion points we had now. In fact, even holding a mask is an art. So majority of the youngsters are those who are still new to the field. They overdo things. Like we do talk about neutral position, we do talk about using special mask for the pediatric age group, but ultimately it's an art. So trying to hold the mask with the right position, right pressure, right pulse and pressures, everything that's more important.
Very true. And if there is only one skill that we can pick up by the end of our PG, it should be mask ventilation. Everything else is optional, and it doesn't matter whether we do it very well or not, because we will not lose a kid. But mask ventilation, if we do badly, we will lose a kid.
Yeah. Is there a role for Larson's maneuver?
Again, I would not trust my life on it or the kid's life on it, more importantly.
Yeah. That's true. That's a practical thing. Is there a role for lignocaine spray before intubation?
Yes, I think rather than before intubation, the evidence is more that it is closer towards extubation that it's better, because if it's a 2-hour, 3-hour surgery, your topicalization of the cords will not last that long. Yeah. So if you're going to topicalize, it's probably a better idea to topicalize towards the end. And actually, as I also said, there was a meta-analysis on this by Mihara et al. From Japan, looking at multiple studies. And what they have said is the route doesn't matter. About 1 to 1.5 mg per kg of lignocaine given in any route about 5 to 10 minutes before anticipated extubation is better. So it doesn't have to be topical. It can be intravenous.
Yeah. Glycopyrrolate nebulization, which has come into the market, any use preoperatively in patients with increased secretions?
I don't, sir. I don't use. I don't know about your practice.
Yeah. So in fact, when we talk about increased secretions, basically, use of anticholinergics per se is not encouraged in the pediatric age group also, the last 10 to 15 years. So it was a matter of routine previously. So we are not advised to use anticholinergics per se, basically, because of obvious cardiac and other reasons, and the temperature-related reasons. And if indeed somebody has tried to use for a real indication, then it's okay. But only glycopyrrolate and nebulization for increased secretions, I don't know how the pharmacokinetics would work also.
Because drug availability at the receptor level is probably not of any consequence if you're given it inhalational. Yeah,
it has to be absorbed and it has to work. Then cuffed or cuffless tubes, which would be better? We just discussed. You can just convey once again, Dr. Shishir.
Yeah, I think there's an increasing trend now towards cuffed tube. I mean, that debate is always there between a cuffed and uncuffed. Traditionally, pediatric anesthetists tend to be conservative. More would go with uncuffed tube below the age of 3 years. But with the micro cuff tubes that are now available, definitely there is more and more of a move towards using that. Either is fine. Where cuff tubes really come into their own is if you're expecting the kid to need prolonged postoperative ventilation. They're taking this kid to ICU where there may be later on need for tube changes and all that come down. Other than that, there is not really that much of a difference, is my opinion.
So is there a role of positioning towards the end before we extubate? Is there some physiologically positive effect on reducing the complications, especially?
So if we extubate deep, left lateral position, recovery position would seem logical. But if we are extubating awake, it's better that they're with a slight back up, and supine is better because we have better access to the airway. And when all the intubated kids, I extubate on them on their back only. When I do deep extubations, naturally leave them on the side, suction deep, suction what you can see, and take it out, and do not touch the airway till such time as the kid wakes up. That's how I will. Yeah.
So Dr. Jagdish Hegde has asked about the role of steroids. I think towards the end of the presentation, you had the table.
Yes.
But I was also looking into the advice that oral steroids be given in poorly controlled patients. Right?
Yes.
That was,
Yes. 3 to 5 days before, 3 to 5 days before, if you start dexamethasone at 0.6 mg per kg, or you can give methylprednisolone is not available with us oral, but dexamethasone will work, or prednisolone can be given 5 days leading up to surgery. Yeah, 1 mg per kg.
okay. Okay, Dr. Kavya, we have come towards the murmur side.
Yeah.
Does the side of ASD, VSD, size, I suppose, the size of the ASD, VSD, does it have influence on reversal of shunt? Should we be concerned even if it's a small ASD, VSD?
I think the answer has to be, we have to be concerned because, probe patent foramen ovale, even if there is no formal ASD, a probe patent PFO can be high as 25% up to 1 year of age. So we have to presume every kid could reverse their shunt and treat it with the same respect, regardless of the size of the ASD or the VSD, is how I look at it. Lot of comments, sir. I'm very happy that people have paid attention.
Yeah. So there have been good exchanges, basically.
Balavaskar, sir, regarding that absolute eosinophil count.
Yeah, please.
I think what Dr. Yashoda was asking, I don't exactly remember the study, but it was a retrospective study of about 3,000 patients. Basically, in patients who were cleft lips and cleft palate. What they found was, when they did a study, they found that 35% were anemic who had eosinophil counts of more than 500, and about 202 odd patients, that about 29% had eosinophilia itself. And out of 3,100, I think 200, roughly about 200 patients had upper respiratory tract infection. The most interesting part was the perioperative complication was almost 8 to 9%, of which 33.7% was critical incident that occurred during induction time. That was one point. And second point that they concluded was about 77 patients, that is roughly about 40% of the patients, I believe, who developed laryngospasm. And that was the conclusion of that particular study. So eosinophil count is good. The cutoff value is somewhere about 1,500 microliters. But eventually they did not have mortality. So that was about the eosinophil counts. It's good to do because you'll be prepared for the outcome.
But when was the publication date? Was it about 20?
I will fish out and put it on the group, sir.
Okay. What I do feel is like, for example, even when we were doing MBBS and other, probably 30 years ago and beyond, before that, it's very common to have the worm infestation in the pediatric areas.
Absolutely.
Very regular, yeah. And attributable to these, we could also suspect about the hyperreactive airway stages also. So that time it would have had more evidence in support of so-called increased amount of respiratory events. So if it is a recent publication, as you said, definitely we can try to have a relook. And if it
Yes,
is
sir.
evidence, strong
In fact-
evidence, maybe differential count, we should also look for eosinophil count.
Correct, sir. In fact, that publication said about 77 patients had laryngospasm at the time of induction. I'll share it, sir. Once I get.
You should also be looking into the what kind of anesthetic agents they used, what were the available choices those days. So we have all the set of the induction agents, the opioids and the relaxants. So those were the days. Of course, please share. I can also share with other participants here.
Yes, sir. Yes, sir. I'll do that.
Of course, Dr. Nagendranath has contributed a point. He says Redmed tablets are available, methyl prednisolone.
Yeah, thank you.
For
Wasn't aware of that. Yeah, thank you.
So, what is the take home for risk of laryngospasm in terms of weeks after a URTI, and risk of to avoid the risk of bronchospasm? How many weeks to avoid the risk of laryngospasm? How many weeks?
I think again, it's going to be 6 weeks is what we would have to say. But to have a pure window of 6 weeks of complete good health is also very uncommon. So you're not going to get that thing. So I think cold score is actually, we are looking at it, sir. One of our postgraduates, a pediatric postgraduate, has taken it up as their DNB topic. Thesis dissertation topic to look at cold score and see how the validation happens, because this is still a relatively new concept. But if we can really come up with a nice validation study, that will be excellent. And maybe something as a senior academician, if you think it's a worthwhile thing to do as a multi-center trial, it might be an excellent idea.
That's definitely validity is important. Bigger numbers and multi-center trial would be definitely useful. I agree. Dr. Azam has shared the study. Good. I'll use it. In fact, what was pending, but I will not extend the discussion. We normally talk about, yes, of course, URTI, and you said murmur and other things. Anemia also comes into mind. Probably we can have a session in future. That's a simple discussion, but we are more frequent in private practice. Basically, when you talk about children with hydrocele hernia group, we get children with 7 grams, 8 grams in Indian conditions even now. And majority of the times, we still go ahead in the absence of any significant clinical manifestations. So I think we can have a separate class on that.
So in fact, it's interesting because a post-operative apnea risk is what Professor Balbhaskar is alluding to with those situations. And while in GOS, we tried to power a study. And for that, I did a survey of anesthetists to ask what they would think would be an acceptable risk of apnea. And they said 0. So it is virtually impossible to power any study to look at what post-conceptual age. Traditional teaching has been 56 weeks to 60 weeks. But again, Malviya et al., they've shown less than 48 weeks post-conceptual age with no anemia and no recovery room apnea has a very low risk of post-op apneas. But it is virtually impossible to power anything because we are naturally risk averse in pediatrics. But that will be another interesting discussion at some point.
Yeah, definitely. We can have it later. And I think inhalation agent of choice in pediatric asthma patients.
Sir, I have.
Okay, that's a small question. Yeah, please, sir. Please, Dr.
Sir, I have a question to Shishir. Not to do with asthma or anything. Is there a cutoff limit for blood transfusion, Shishir, in pediatric?
I think a transfusion trigger, numerical trigger as such is not there, but all that means is that I think you just keep the kid in overnight, because the risk of apnea is what we are worried about because of the central apneas. So we just keep that kid in for 1 day post-op and then discharge. So we don't transfuse necessarily, no.
So even if the hemoglobin goes down to 7.9 or something, or 7 or something, it's okay to have that?
It's okay to proceed with surgery, provided you keep the kid in hospital for at least 24 hours. Yeah.
Okay. Thank you. Sir, this publication was 2013, sir, if I'm not mistaken.
Must be a good one. I think I'll try to go through it.
Yes, sir.
Thanks a lot. Dr. Kavya has asked, what is the minimum age for which you are using magnesium sulfate?
So magnesium is like one of the new wonder drugs that is becoming more and more. It's quite a good drug. And if you think about body stores of magnesium is something in the order of 80 to 100 mg per kg. in a child also. So what we typically use is 15 mg per kg. 15 mg per kg is a safe dose to use even in 6-monthers. We have used, and not only just for laryngospasm, but it obviously has other additional properties of excellent bronchodilation, excellent as an anesthetic, analgesic adjuvant. So 15 mg per kg is what I have used. 6 months and above, I do use.
Okay. That's a good drug. Only thing is we should get used to how you administer and the percentage concentrations which is available.
Yes.
55%, 50%, and how to constitute that.
Yeah. So usually 2 ml ampule comes at which will be 500 mg. So you can just dilute it down to 15 mg per kg, and we put it into your fluid of choice and run it slowly, because you don't want that acute vasodilatation to happen. Yeah.
So we are used to administering it in obstetric patients.
Yeah, 4 grams. Yeah.
4 grams.
Yeah.
Okay, so people are still posting questions, but let us take the last question, I think. But there are important ones for postgraduates also. The route of succinylcholine when IV line is lost. More general question. Yeah.
I think only choice you have is you do the best you can, and you will probably give about thrice as much. You'll give about 4 to 5 mg per kg would be your dose, and into a more well-perfused like anterolateral thigh or something like that. But again, it is more often than not, if you anticipate early, keep a patent airway as best you can with CPAP. We seldom have to use choline, and if you are using choline, especially in the setting of bradycardia, definitely you have to also give an anticholinergic, because almost certainly it will worsen the brady. And again, that's a contentious issue, because do you really want to give atropine in an already stressed heart? Because if you think about the brady, it's a teleological mechanism of self-preservation and reducing myocardial work, and you're actually increasing myocardial work without increasing supply. But that's a discussion for another day.
That's a bigger discussion.
Yeah.
It's okay. Dr. Anju has given a suggestion. Sublingual succinylcholine. Yeah, that I also wanted to suggest, but it's part of. For example, I have not administered. For example, even the earlier days, where even we were maintaining the patients with scalp pain sick, some of the neonates. So those days also we didn't at any point of time try the sublingual route. But sublingual approach, as Dr. Anju is telling, definitely is theoretically possible. And when you're writing the theory, we can definitely suggest this as a last option that can be there.
There's also a message about TIVA. And that's a very valid point. And in fact, as TIVA becomes more prolonged, more prevalent in our system, it will definitely take over more and more of our pediatric practice also. But again, we have to be very careful in extrapolating Western data in our context, because in Western data by TIVA, they mean classical TIVA with propofol and remifentanil and nothing else. No dexmed, no ketamine, none of that. So we have to be careful. It is the classical TIVA that they're talking about. But yes, there was one study where there was a huge difference. I think that's what I think MS has put. I don't know, sorry, who that is. But definitely there was a p-value was less than 0.01 in the difference between TIVA, and I remember that reading that study. But I didn't put that as a initial thought, because it is not a technique we are very used to. Yeah.
Of course, it's still a matter of balanced anesthesia. So CO still has got a place, propofol has got a place, ketamine has got a place. So it's left to your individual experience as a pediatric anesthesia. Yes.
Agreed.
Okay. We must avoid histamine-releasing drugs. Yes, agreed. like succinylcholine, atracurium especially. And of course, I think we are waiting for remifentanil. Probably at any point it can enter into our market also.
Next week is what I am reliably told. So the guys from Themis had come to meet just 3 days ago, and I think the licensing is all done. Next week is they're saying, but we've heard this next week many times.
Next week, we'll talk about pricing issues, but anyway, good thing it's going to come. It will help us in maintaining the pediatric patients better also. Thanks a lot, Shishir. And
yes,
I think Dr. Srinivas, you're online. Dr. Srinivas.
Hello, yeah, I'm online. Thank you, Shishir. It was an excellent and informative presentation. I know still the questions are trickling in. The discussion was so interesting. Thank you for accepting our invitation. Thank you very much.
My pleasure, sir. Thank you. Thank you. I always hold the Bellary group in high esteem because I am from Mysore, and I used to think Mysore had a nice close-knit group, but I have met many people from Bellary, and that bond that you people have is something extraordinary. I have not seen with any other medical college.
Thank you. Thanks for the compliments. And we come to
Thank you.
the session and active participation from all people, all our colleagues today. Dr. Azam also had a good input in Dr. Anju, lot of senior members. Dr. Ganesh Tundulkar was there.
Kuchela Babu was also.
Dr. Kuchela Babu sir was there, everybody. And of course, Dr. Srinivaslu has got some dental issues. So
Yeah,
he's to participate.
I have experienced
Yeah.
the nerve block. Even now it is numb.
Yeah. So we should suffer to understand how patients suffer also. Right.
Yeah. Now I have experienced it.
Oh.
Yes, thank you.
So thanks once again on behalf of ISA Ballari and VIMS Anesthesia Alumni Group, today's speaker, Dr. Shishir, and all the office bearers of ISA Ballari and other places in Karnataka and across the country. Thank you very much. Good night, everybody. Bye.
Thank you very much, sir.
Thank you.